Hello, everyone, and welcome. I will be talking about a crucial topic that affects millions of Americans: Medicaid financing. I want to focus on the ways the government generates funding to support this vital program. Whether you're looking to understand how Medicaid supports low income individuals or just curious about the intricate details of healthcare financing, you've come to the right place. So let's dive in and explore how Medicaid financing work, how much does Medicaid cost, and how our funds is spent, and why it's so important for our communities. How does Medicaid financing work? Medicaid is a joint federal and state program that provides health and long-term care coverage to low-income people. A lot of people confuse Medicaid with Medicare. Remember, the two are not the same. Medicaid is not the same as Medicare. Medicare is a federal health insurance program that covers individuals 65 and older or under 65 with certain disabilities or kidney failure. As I mentioned earlier, Medicaid is a joint federal and state program for people with limited or very low income. Medicaid covers 1 in 5 people in the U.S., and it accounts for nearly $1 out of every $5 spent on healthcare in the United States. To participate in Medicaid, federal law requires states to cover certain groups of individuals known as mandatory eligibility groups. These groups include low-income families, qualified pregnant women and children, low-income older adults, and individuals with disabilities who are receiving supplemental security income. In addition to these mandatory groups, states have the option to expand coverage to include optional groups. These are individuals who do not meet the criteria for the mandatory eligibility groups. States have some flexibility in covering these optional groups, which may include individuals with incomes that exceed the limit set for the mandatory groups. Examples of optional groups include the medically needy or those with high medical needs who earn too much to qualify for the mandatory group. Another one is the elderly individuals whose income is above the mandatory coverage limit. While states are required to cover mandatory benefits, they also have the option to expand their coverage to include optional benefits. Additionally, states have the opportunity to receive federal matching funds for providing these optional services, which can include adult dental care and home care services, often referred to as home and community-based services. Remember, Medicaid is an entitlement program. Those who meet the requirements must be enrolled. Now, let's take a look at the mandatory services and the optional services. So we're right here at the Medicaid.gov webpage, and we're looking at the mandatory and optional Medicaid benefits. You will notice that we have here under the mandatory, we have the inpatient hospital services, outpatient hospital services, as well as the physician services. But then down there at the optional, you can see the physical therapy, private duty nursing, occupational therapy, speech, and even the prescription drugs are under the optional benefits. So don't forget to visit this website and check for the mandatory benefits and optional benefits. Now that we understand who Medicaid is helping and what services it finances for its population, let's discuss the source of funding. Medicaid receives its funding from both federal and state sources. First, let's focus on state funding. We will begin with the non-federal share of Medicaid payments. States have a unique approach to financing their non-federal share. Their funding sources include state general funds, local government funding, and revenue generated from provider taxes and fees. The state general fund consists of revenue collected by the state, which can vary from state to state. In my state, the main sources of general fund revenue are individual income taxes, retail sales taxes, and the state lottery. Other common sources for many states may include corporate income taxes, general sales taxes, individual income taxes, and various business taxes, as well as alcohol and tobacco taxes and miscellaneous fees. The local government funding can come from various sources, including property taxes. What are provider taxes? Provider taxes are fees or assessments on healthcare providers the states use to help fund Medicaid. They are also known as healthcare-related taxes. States can use provider taxes to claim additional federal Medicaid reimbursement. States have the flexibility to apply provider taxes in different ways. They can target specific providers such as hospitals, health systems, nursing facilities, and managed care organizations. Additionally, states can decide the basis for applying the tax, whether per admissions, per bed, or per percentage of net revenue. In the fiscal year 2024, 49 states and the District of Columbia imposed at least one healthcare-related tax. I find provider taxes to be very beneficial because the provider taxes, along with the local funding, help finance disproportionate share hospital payments and other non-DSH supplemental payments. Some hospitals serve a significant number of Medicaid patients as well as low-income uninsured individuals. These hospitals receive what are known as disproportionate share hospital payments, which are supported by provider taxes and local funding. The DSH payments are part of a broader category of supplemental payments that states provide to help cover Medicare costs. These supplemental payments are crucial because base payment rates often do not cover the full costs that providers incur. What distinguishes DSH payments is their ability to help cover unpaid care costs for those who are uninsured. This is a complex system, but it is vital for ensuring that hospitals can continue to provide care for vulnerable populations. I have noticed that many people believe the solution to controlling healthcare costs lies in decreasing what payers are willing to pay. However, they often overlook the providers' need to cover their costs. If the providers cannot meet their expenses, they may struggle to remain viable and they may not be able to continue offering essential services. Now let's discuss the federal source of funding for Medicaid. We'll focus on federal matching payments, specifically the Federal Medical Assistance Percentage, commonly referred to as FMAP. This percentage varies from state to state and is influenced by factors such as the types of services provided and the enrollees. The Federal Medical Assistance Percentage, FMAP, is a formula used to determine the federal government's share of Medicaid and Children's Health Insurance Program costs for each state. The Federal Medical Assistance Percentage is calculated based on the state's per capita income relative to the national average. Per capita is a term used in economic and statistical analysis that means per person. This is the formula for the Federal Medical Assistance Percentage. Now, what is the range for Federal Medical Assistance Percentage? This ranges from a minimum of 50% to a maximum of 83%. By law, a state's Federal Medical Assistance Percentage rate can be no less than 50% and no more than 83%. Keep in mind that for medical services provided to enrollees made eligible by the Affordable Care Act, the federal share of Medicaid costs is fixed at 90% and does not vary by state. So the federal share for ACA-eligible Medicaid recipients is always 90%. Meaning it does not fluctuate based on a state's per capita income like other Medicaid populations might. Now, when it comes to the states, while the federal government covers the majority of the costs, the states still bear a portion of the expense for ACA Medicaid expansion enrollees. This provision primarily applies to adults who became eligible for Medicaid through the ACA's expansion of coverage. The states with lower per capita incomes receive a higher federal medical assistance percentage, meaning the federal government pays a larger share of their Medicaid and CHIP costs. For example, in this Kaiser Family Foundation article, it mentioned that in the upcoming federal fiscal year 2026, it'll range from a low of 50% in states like California and New York all the way up to 77% in Mississippi. As you see, this rate starts at a minimum of 50% but can go higher for states with lower average incomes. The federal medical assistance percentage adjusts based on economic conditions. For example, we saw temporary boosts during downturns like the COVID-19 pandemic. To participate in Medicaid and access those federal matching dollars, the states need to adhere to some core federal requirements. As we mentioned earlier, they must offer mandatory benefits to those who meet the mandatory eligibility categories. We also mentioned that the states can cover optional groups like those that didn't meet the mandatory group criteria, and that they can also offer optional services. These services must be provided without any waiting lists or enrollment caps. Remember, Medicaid is an entitlement program. Those who meet the requirements must be enrolled. Also, there's no cap or no limit on how much the federal government will match what the states spend. Now let's talk about Medicaid funding in the U.S. territories and how it differs from the states and the District of Columbia. Unlike the 50 states which receive annual federal funding without a cap, U.S. territories face a fixed limit on their Medicaid funding. What that means is that once they hit that cap, they cannot access additional federal funds for their Medicaid programs for the rest of the fiscal year. We now have an idea about how Medicaid is funded. There's the state, general, and local funds along with the provider taxes and fees. And we also discussed about the federal matching dollars and the formula of the federal medical assistance percentage, which goes higher for states with lower income per capita. We also talked about the mandatory and optional services that the states provide to the mandatory and optional groups. We can now talk about the states being able to decide how to purchase these covered services. They might choose between a fee-for-service model or a capitated managed care arrangement, and they have the autonomy to set the payment methods and rates for providers. The fee-for-service and capitated payments are both ways to reimburse healthcare providers, but they differ in how much and when they are paid. So for fee-for-service, the providers are paid for each service they provide. The more services a provider performs, the more they are reimbursed. This model allows patients to choose their preferred providers and access a wide range of services. Now, for the capitated payments, the providers receive a set amount per patient per month, regardless of how many services they provide. The payments are made in advance for a set period of time. The goal is to balance patients with low utilization with those who use more services. Now, there are benefits of each model. Capitation can help improve care experience, population health, and reduce healthcare costs. Now, fee-for-service can offer flexibility and transparency, and it allows the patients to choose their providers. Both models can work well with the right structure and regulation. Now, let's talk about an important aspect of the Medicaid program. Program integrity. Both the federal government and state governments share the responsibility for ensuring that Medicaid runs smoothly and efficiently. When we say program integrity, we're referring to the effective management of Medicaid, making sure it delivers quality care while using taxpayers' dollars wisely and minimizing wastes. In the recent years, we've seen reports of improper payments that highlight some issues surrounding program integrity. Both of the previous administrations have taken steps to address these concerns, though they have different ways for approaching the challenges. Improper payments are payments that don't align with the requirements set by the Centers for Medicare and Medicaid Services, or CMS. This can include overpayment, underpayments, or payments made without enough information to determine if they are appropriate. It's important to note that improper payments are different from criminal activities like fraud and abuse. So, interestingly, a significant portion of the improper payments were a result of insufficient information or missing administrative steps, rather than payments being made for ineligible individuals or services. So, this means that many claims should have been valid if the necessary information had been provided. When it comes to improving program integrity, focusing on major contributors to improper payments, such as monitoring, provider screening, and enrollment, is more likely to produce better results than tightening eligibility determinations. Because if there's more strict eligibility checks, this could inadvertently make it harder for those who are eligible to access and maintain their coverage. Remember, promoting program integrity is key to ensuring that Medicaid serves its purpose effectively and efficiently. By addressing the root causes of improper payments, we can work together to enhance the overall integrity of this vital program. Now, let's move on to our next topic. How much does Medicaid cost and how are funds spent? Let's take a look at this Kaiser Family Foundation article. For federal fiscal year 2023, the total Medicaid spending is $880 billion. Managed care and health plans represented the largest portion of Medicaid spending, accounting for 55%. Now, within this, 52% is from capitated payments to comprehensive managed care organizations. Then the other 3% is from other forms of Medicaid managed care. The remaining shares of the total Medicaid spending in federal fiscal year 2023 included fee-for-service acute care at 21%, fee-for-service long-term care at 19%, and you'll see here the 6% institutional long-term care and 13% home care. Medicaid spending for Medicare premiums on behalf of enrollees who are also on Medicare is at 3%, and disproportionate share hospital payments is at 2%. Overall, the capitated payments to Medicaid managed care organizations accounted for more than half of Medicaid spending in federal fiscal year 2023. Now, this makes sense because the capitated payments seem ideal if the goal is to balance patients with low utilization with those who use more services. Remember that with capitated payments, the providers receive a set amount per patient per month, regardless of how many services they provide. And some of the benefits of capitated payments include helping improve care experience, population health, and it reduces healthcare costs. Now let's move on to the total spending per full benefit enrollee in Medicaid. So in 2021, the total spending per full benefit enrollee in Medicaid varied quite a bit from state to state. So for instance, Tennessee had the lowest spending at $3,563, while the District of Columbia topped the list at $12,008. Now, this variation highlights the flexibility that the states have when it comes to designing and managing their programs. Now, each state can decide what benefits are covered, and they can set payment rates for providers, and this leads to differences between the states. We see significant variations in costs among different eligibility groups within the states, and even within the same group, the average cost per enrollee can also vary. Thanks for joining me today as we navigated the complexities of Medicaid financing. It's crucial to understand this program's financing and the ways it supports millions of Americans who rely on it for healthcare. Whether you're a healthcare worker, a health insurance broker, a healthcare provider, or just someone looking to learn more, these insights can help clarify the importance of adequate funding and support for our healthcare system. Please don't forget to like and subscribe for more videos like this. Let's stay interested in how we can improve healthcare accessibility and affordability. Until next time, take care and stay informed.